3D printing and implants as well.
One question from my side also. How do you manage the implants? Like yesterday I was doing a case with a stabler fracture. When I opened it, there was a screw inside the joint and the plating was done from the interior side. So how you handle those situations?
So this is a very common scenario when the patient has already been done an pass with an anterior column plate and I'm doing for the posterior part. So these pelvic plates are, if the patient has already on a pelvic plate most of the times, you can just put a punch and hammer those screws back. You cannot go entirely and remove the plate and do everything. Na? Just hammer, because since it is not a locked plate, so just disimpacting or punching the screw will put it back. So it has happened a few times and I did. Sir? Hi, sir, you can cut it also.
I did the same, I cut with the wire cutter.
You can just punch it, it is cancellous bone and it will go inside the pelvis obviously, but well, that is the bailout situation.
So I cut it and put a bone graft over it and then reverse rimming.
Or you can use a bar type of thing, metal bar. Thank you.
Good afternoon, everyone. So I'm going to talk about dual mobility cups, current indications. As we all know that hip dislocations is a surgeon's nightmare, and it is one of the earliest cause of revision in total hip replacement cases. So what is the implant malposition responsible for this? But there are multiple studies which says that 58% of dislocating total hips, they had their acetabular component placed within the safe zone. So then why the hips are dislocating? So instability is likely multifactorial. There are multiple factors which are responsible for this. So the range of dislocation right from the primary to revision, it ranges from 10% to 28%, which is quite high. So there are multiple factors like patient-related, surgeon-related, and certainly the implant-related. So today I'm going to focus mainly on the implant-related factors. So apart from avoiding malpositioning of your implant, what else you can do to improve the stability of the hip? So one option is you can use a large diameter head, that is more than 36 mm. But the problem with large diameter head that you have to use a cup size. It's only used after, like in multiple companies, if you use cup size more than 52 mm, then only you can use a 36 mm head. So which is not a scenario in our patients. Females, they have a very small cup size. So we cannot use large head diameter in every patient. And also, if you use the large diameter head, it will decrease the thickness of your liner. So the next option is dual mobility cup, which we can use. So basically, dual mobility cup, it's an interposition of a mobile polyethylene layer between the prosthetic head and the acetabular cell. So the concept is that primary movement occurs at the inner bearing and the outer bearing only moves at the extremes range of movement. So it increases the jump distance. And it's based on two orthopedic principles, that is Chanley low friction orthoplasty and McIferrar large diameter bearing theory. So it's a large diameter head, increased jump distance and reduced dislocation rates. It was defamed initially because of high intraprosthetic dislocation rates and high risk of wear. But after FDA approval in 2009 and improvement in design and metallurgy, it has again gained its role in total hip. So this is the data which has shown that there is consistently increasing trend towards using the dual mobility cups. So can we use, if it's that good, then can we use in every patient? So there are multiple studies which says that it has got excellent mid-term result, but the long-term data is still awaited. There are other studies which was discussed in American Hip and Knee Society meeting that should I avoid when it possible. So they advise that its selective use in patient with high risk of post-op dislocations. So where I use dual mobility cup, primary scenario in displaced fracture neck of femur in elderlies, THR in spinal fusion patients, patient with muscular weakness or poor cognition. In revision scenario, particularly when you are converting a HRA to THR, in patients with recurrent instability, and sometimes in revision THR scenario, you can use dual mobility cuffs. So the most common indication, that is neck of femur. Neck of femur, I mean, doing a THR in neck of femur is a different ball game. I mean, there are very high risk of dislocation because of multiple factors. So we have to be very cautious, particularly dealing with neck of femur. So these are the cases: 74-year-old female community ambulator did a THR with dual mobility cup. Another case, 70-year-old lady community ambulator, history of CVA, did a THR with dual mobility cup. Another case, 63-year-old female, she had a broken stem, AMP was done 10 years back. It was revised, long stem, long Wagner stem on the femoral side and dual mobility cup on the Stabler side. 3-month post-op, these are the 6-month follow-up X-rays. Another case, 60-year-old male with recurrent dislocation, cemented bipolar, did a cemented THR with dual mobility cup. He came to follow-up after 6 months following a fresh fracture. Implant was stable, which was fixed. And the other 7-month post-op X-rays. Another case, 87-year-old obese male with non-union IT fracture. Dual mobility cup and a Wagner stem was used in this case. 6-month follow-up. This is 1-year follow-up. Patient is walking comfortably. Another case, 75-year-old male stem neck fracture, 1.5-year-old cemented bipolar, revised with a dual mobility cup and long stem on the femoral side. Another case, 58-year-old female, obese, limited mobility, grade 2 protrusio, use a PSL cup, both the side build dual mobility, and impaxum grafting, 1-year follow-up, 2-year follow-up. So my take-home message is dual mobility cups, they appears to be a safe, durable, and effective solution to hip instability. This concept has extensive lab and clinical support. It's an alternative in high-risk patient population, and in femoral neck fractures. Long-term data is still awaited to support its use in every primary hip arthroplasty cases. Thank you for your kind attention.
Questions? So, Rama, as you said, long-term data is still awaited, 15-year, 20, 25-year follow-up. So, at this stage, what is your ideal indication for using dual mobility cup?
I just said, I've been particularly in neck of femur cases I will use in elderly patients, and patient with the spinal fusions where the dislocation risks are high in those cases. In revision scenarios, particularly if a case of recurrent dislocation, HRA, you are converting to a THR, in those cases you can use dual mobility.
For me, the first priority is abductor deficiency. Patient is having this sciatic nerve palsy type of thing. So those who having abductor insufficiency, that is the most ideal candidate for dual mobility. Rest, as you have explained in a good way. Thank you.
Thank you.
Sir.
Sir. Mike.
So in 75-year-old ladies who are community ambulators, why are you doing a THR rather than a bipolar? Because today there's enough evidence to show that the bipolar works well over a fairly long period of time. So I think doing a THR probably exposes them to further complications. I think it's just...
My understanding is, sir, if a patient is home ambulator, then I will do a bipolar. Otherwise, if it's a community, if he's roaming around in community, then my preferred implant would be a THR.
I think if you're in Germany, you probably would do a THR, but I just feel that there are obviously some increased risks when you do a THR rather than a HEMI. In a fracture neck femur patient who's already compromised medically. So it's something that you have to think about before you do it. I just feel that.
Sir, just one question for you. Like in neck of femur, at what age you will do a THR?
So for
and
me,
when you consider doing bipolar?
So the age is not the factor.
Okay.
It's either a really fit person who is very active and it's a fracture which you can't fix. So both the two things. And the second thing is where there's already a pre-existing hip problem. So there I would definitely go for a THR. But we've been doing bipolars with, I mean, we've got now 20, 15, 18-year results with absolutely no problems at all so far. Of course, there will be some who will have problems, but the numbers are really small to really think of not doing it altogether and doing a THR in some of these patients.
Since in the UK, I would quote some UK data. So NICE, National Institute of Clinical Excellence, has got guidelines which is oft quoted and used in day-to-day clinical practice due to huge burden of neck of femur fractures. So chronological age is taken into consideration, not the biological age, and the physiological age, not the chronological age. And second thing is, there was an arbitrary criteria: if you can walk a mile without pain, then you are possible candidate for THR, otherwise you get a bipolar. And comorbidities wise, there was the ASA grade. So if you fall into ASA grade 2 or more, then you probably are candidate for a bipolar, and if you are ASA 1 or 0, then probably get a THR. But yeah, bipolars in UK, they actually do not use even bipolar. They will use a monopolar, monoblock striker one, which works very well. I have done more than 500 of them, and very few of them, less than 1%, would have come for revision for a THR in those cases. So that's well worth considering in our scenario as well.
Any more questions? Thank you.
Thank you for the wonderful presentation. Now may I request Dr. Siddharth Gupta to present his case.